Hello students, welcome to the final session of the spine trauma module. Today we'll be discussing about sacral and spinopelvic injuries. So whenever a resident learns about spine trauma, the most neglected part of that learning or that curriculum is that they learn about cervical fractures, they learn about thoracolumbar fractures, but they forget to study about sacral fractures. They'll even go on to study about pelvic trauma later on, but that integral part between your lumbar spine and between your pelvis is usually missed out, and that is very important because there will be case scenarios like this. So we had this patient coming to our casualty, a 25-year-old lady. She had a fall from height 30 feet directly on her legs. It was a suicide attempt. There was pain in the lower back when she presented to us. She had radiating pain on her legs, normal motor power, sensory deficits were there around the perineum, and patient had bladder retention and weak anal sphincter. Now while working up this patient, the resident did get x-rays of the thoracolumbar spine. The resident did get a pelvis x-ray, as you can see here in the slide, and also get some other trauma series where they picked up calcaneum fractures, they picked up thoracolumbar fractures, but they never went to look for sacral fractures. And that is, I think, the problem with the mindset of evaluation. If you don't understand about sacral fractures, you will never be able to know what to look for when you're seeing your clinical examination, when you're doing your x-ray assessment, and also you don't know what imaging to get later on to really clear out whether there is a sacral fracture or not. So in this patient, he had sacral fractures, and that sacral fractures were missed out. Now, sacrum as a whole will never come as a 10-mark question in your DNB exams or in your RGHS exams, but it is important for you to understand about sacrum fractures, spinopelvic injuries, how to manage them, how to classify them, because when you get clinical scenarios like this, you will get an idea as to how to proceed. Because it's very difficult to pick up sacrum fractures even in this x-ray. In this x-ray again, I would never have picked up a sacrum fractures, but if I knew the details of the case, if I knew that patient had weak anal sphincter, bladder retention and pain along that area, I'd have this suspicion in my mind that there could be a sacral fractures, and I'd get higher investigations dedicated to the sacrum, and maybe sacrum fractures wouldn't have been missed out. So it's important for us to know in that way what a sacral fracture is and how does it present to us. Okay, first let's understand a little bit about this neglected bone called as a sacrum. So let me show you this bone is your sacrum. It's a very important bone in the body because you have your lumbar spine that is connected here, that forms your L5S1 articulation along these facets, and then you have the sacroiliac joint going in here that forms the articulation to the pelvis. So really your lumbar, your axial spine and your pelvis, an important connection to that is this bone called as the sacrum. So as you can see here, this is your sacrum. This is the whole spine, and the whole spine is supported on this one bone called as the sacrum, and you have your SI joints that again form the pelvis. So this bone can be called as the keystone in your pelvic and spinopelvic articulations. So sacrum is important because it is the lowest functional portion of the spinal column. It provides an anchor for the mobile lumbar spine. That L5S1 articulation is extremely important for the movement of the lumbar spine. And whenever we see someone describing about the functionality of the sacrum, that one word that you will always see them use is it is a keystone. If you're aware of what keystone is, if you looked at beautiful architectural structures, you would have noticed that there's always this one integral stone in every pillar or every architectural model, which is very important for the integrity of that whole structure, and that is the keystone. So even your sacrum has that keystone or reverse keystone configuration, which is helpful in your lumbopelvic and your lumbosacral articulations. Okay, let me show you how that works, how the keystone and reverse keystone function works. So we know that all of the weight first is subjected on the axial spine, and from the axial spine all of that weight gets transmitted through the lumbosacral articulation into the upper sacrum, and from the upper sacrum it is propagated laterally along the sacroiliac joints, and then it goes into the pelvis. So the middle structure, the most important structure here is the upper sacrum and the sacral body and the S1 joints. So how does this articulation help? How does this keystone function come into play? So look at this pelvic outlet view. So this is the outlet view of the pelvis. So in the pelvic outlet plane, you can see that the orientation of the sacrum is in such a way that it acts as a keystone relative to the ilium, so that all of these axial forces that are coming into that area gets locked at the sacrum, gets locked with the pelvic ring, and it stabilizes the SI joint. And that is how your pelvis can remain stable, because the sacrum acts as a fixed keystone, a true keystone, and stabilizes all of these axial forces. So that's how it acts as a true keystone. How does it act as a reverse keystone? Now look at this pelvic inlet view. Here this is a inlet view. In the inlet view, the sacrum is shaped like a reverse keystone, not like a keystone, it's like a reverse keystone, which makes this whole pelvic articulation little unstable. And that unstable part is very important, because that instability, that inherent instability, helps in some movement of the pelvic ring. So that movement of pelvic ring is allowed by this reverse keystone position, which creates some amount of inherent instability. Okay, so that is how pelvis and sacrum part is important. Sacrum locks it with a true keystone appearance, and in the reverse keystone it allows some pelvic ring motion to occur. Okay, that is why sacrum is extremely important. Now let's study about the anatomy of the sacrum. So this, you're seeing the sacrum posteriorly. This is the anterior part of the sacrum. Now, unlike your other parts of the spine, your sacrum has a certain angulation. It has a kyphotic alignment. Can you see here? It has a kyphotic alignment, and this kyphotic alignment is given by the fusion of sacral segments. So sacrum is not a single bone. It has multiple segments that ultimately fuse together. So you have to understand that a sacrum is a composition of 5 kyphotically aligned vertebral segments. And when do they fuse? That again is a very important question. So the fusion takes place from the lowermost segments, and then it goes more cephalad. So the first segments to fuse are these lower 2 areas. These lower 2 segments, they fuse at 15 years of age, and then slowly the next segment fuses, and then the next segment fuses, and by 25 to 30 years your sacrum is like this, completely fused together. You can see this, all this in spinous processes are fused together to form the sacral crest, and you see all of these transverse processes in the side are fused to form the sacral ala. So this is how a sacrum is formed. It is kyphotically aligned. Unlike other parts of the sacrum, it is kyphotically aligned, and it is completely fused at 25 to 30 years of age. Now let's try to understand a few important segments of the sacrum, and the most important one is this ventral aspect of the upper S1 body. So this is that ventral aspect of the upper S1 body that is projected. If you can see here, it is projected anteriorly and it is projected superiorly. This part is called as the sacral promontory. As you can see marked in blue here, this is the sacral promontory. So what is the use of sacral promontory? One of the uses is that it has a very thick bone. It has good support where the lumbar spine can sit through. The second is because it has a very good bone stock. Whenever we put an S1 screw, we are advised right from our residency days that whenever we put an S1 screw, to always aim it at the sacral promontory, because you know that sacrum is a little bit of a hollow bone. So purchase is sometimes an issue. So whenever you put a screw in S1, you can target it at the sacral promontory, and this way you're getting a bicortical purchase, a good bicortical purchase, and those screws are more stable. Okay, so that was about sacral promontory. The next part that you have to understand is the sacral body. This part here, right behind which you have your canal, this is your spinal canal, this is your sacral body. This again has a good bone stock, has a very dense bone, and this lies medial to the neural foramen. So these are all your neural foramens. It lies medial. So this good stock of bone that you can see here, this is the sacral body. And then, like I told you, by the fusion or coalescence of all the sacral transverse processes, you have this part of the bone in the sides, lateral to the neural foramen. These parts here, these are called as sacral ala. It is the largest portion of the sacrum that articulates with the ilium. It articulates with the ilium here to form the sacroiliac joint. It forms the sacroiliac joint, and this bone is cancellous. Your cortical bone here in the center in the body is thick, but in the sacral ala you have a cancellous bone. Okay, that is an important information to know. Next, you have to understand about what happens and what kind of fractures can occur because of weak zones and transitional zones. So like I told you, there is a combination of cortical and cancellous bone. So your sacral body and your sacral promontory, all of them have a good bone stock, increased bone density is present. But the lower parts of the sacrum, these parts of the sacrum, along with sacral ala, even the sacral ala here, which is marked in blue, all of this have a reduced bone density. So if a bone has to fracture, the weakest zone is the transitional zone, somewhere down here between the junction of good cortical bone, good bone density, and reduced bone density. This is where the break can happen, and this break will now try to transmit more laterally but it will not be able to do so because the SI joint is very stable. So this fracture, as it starts here in the transition zone, will then slowly exit more superiorly. It will slowly exit more superiorly. Let me show you in the image as well. So the fracture will occur somewhere here, transition zone of the good bone density and poor bone density. Then it will slowly travel front, and you will have this U-shaped fracture at the junction of body and sacral ala. That is again a transition zone. So this is how usually your fracture patterns will be, always going into the SI joint, L5 S1 articulation as well. So this is the main reason for this, is the transition zones between the area where there is good bone density and poor bone density. Okay, is this clear? Do you understand now how fractures can occur in sacrum? Now to understand about bony anatomy of sacrum, so I've shown that in this image as well. So this is your anterior area, this is your posterior here. Here again, this is anterior, this is posterior. Now in the anterior part, the first thing that you have to understand is the base. This is your base, and this is the sacral promontory here. Let me mark it in the image as well. This is the sacral promontory, that was the base. And then in the sides here, you have your sacral ala. So this is the sacral ala, which has a cancellous bone. And then there are foramens right from S1, S2, S3, S4 going downwards. Then you have this coccyx or tailbone on which you sit. Coccydynia is one of the symptoms that occur when you have an abnormality in the coccyx. And then let's go more posterior. Now as you go posterior, you will notice that because of the fusion of all the spinous processes of the sacral segments, you have something called as a sacral crest. This is your sacral crest. You have a mid-sacral crest, an intermediate sacral crest, and a lateral sacral crest, and all of them join here. If you can see here, there is an opening here. This is called as a sacral hiatus, and this part along its opening is called as a sacral cornu. So this is the sacral cornu, and this is the sacral hiatus, and you have all of your quad equina nerve roots going in from here, being there inside that hiatus. So in patients who have severe radiculopathy because of a lumbar pathology, we usually think of, if medications don't work, we usually think about giving them injections. Options are, you can give an epidural injection, you can give a selective nerve root block, and some people even prefer giving a caudal analgesia. What you do in caudal analgesia is you take this marking here, that is your sacral hiatus, and through this you give the injection which goes into the quad equina nerve roots, and patients feel relief because inflammation reduces and the radiculopathy also improves. So this sacral cornu and sacral hiatus is an important landmark when you're giving a caudal analgesia. Is that clear? So that was about the anterior and posterior aspects or the bony anatomy of the sacrum. Now coming to ligamentous anatomy. So we have to discuss about ligamentous and neuroanatomy, and then we can move on to the fractures. So 3 or 4 ligaments that is extremely important for you to understand. One is the lumbosacral ligament, which goes from the L5 transverse process and gets articulated. So I'll show you in this image as well. From the L5 transverse process, it goes into the S1, S2 sacral ala. Okay, this is the lumbosacral ligament. Then you have the sacroiliac ligament, which is present anteriorly and posteriorly to the sacroiliac joint. So it connects the sacrum to the iliac bone from the anterior side as well and on the posterior side as well, as you're seeing in this image here. Okay, then you have sacrospinous and sacrotuberous ligament. The articulation is self-explained in that itself. So sacrospinous connects from the S4 sacral spine all the way to the ischial spine. That's why it's called as sacrospinous. Sacrotuberous connects from the S4 sacral spine till the ischial tuberosity. That's why it's called as sacrotuberous. So you have sacrospinous ligament and sacrotuberous ligament, and these are the 4 important ligaments that you need to know about in the sacrum. Then let's understand about sacral neuroanatomy. Like I told you in that scenario that I put up, that patient had normal motor neurology, but it had sensory paresthesia. They had some issues with bowel and bladder. So here it is very important for you to think about, if a sacrum would have been damaged, what nerves would have been involved. And I think the understanding of sacral neuroanatomy would have really helped you understand or suspect for a sacral fracture there. So let's understand what all structures are at risk whenever you have a sacral fracture. So whenever you have an upper sacral fracture, always at the sacral ala, right behind the upper sacral ala, you have this L5 nerve root that is coming out. So that L5 nerve root can get damaged whenever you have a sacral fracture, and patients might present with foot drop. Okay, that is one reason. Another is you might have a sciatic nerve injury which runs in very close proximity. Then you have pudendal nerve, superior gluteal nerve, inferior gluteal nerve, and also the sympathetic chain can get injured. So these are the 6 nerves that you have to understand, and whenever you see neurological deficits, you always have to correlate for all of these nerves and their examination. Okay. And you have to understand this part, that whenever patient comes in with deficits, mainly deficits of sacral function like bowel, bladder, and sexual dysfunction, it is not just involvement of one side nerve roots. We know that nerve roots are coming out from both sides of the foramen. If only one side nerve roots are involved, it is very unlikely that the patient has a bowel dysfunction, a bladder dysfunction, a sexual dysfunction. It is only when bilateral sacral nerve roots are involved, patient will eventually have these kind of deficits. So please understand this. Patients need to have both areas involved. If both areas are not involved and patient has these symptoms, you have to look for other causes of this deficit. Okay. Then basic examination, what you always do is you examine for L4, L5, S1. You have to do that here as well. Okay, so that was about sacral neuroanatomy. Now you have to understand which injury to neural foramen should give you a higher suspicion of a nerve root injury. So we know that there are multiple neural foramen. So if you can see this image here, there are S1, S2, S3, S4. So multiple neural foramens are present. So if a patient has an S1 neural foramen injury, the chances of S1 nerve root being injured is very high. The reason for that is that majority of the S1 foramen is occupied by the S1 nerve root. So if there is any damage to the foramen, there is a high chance that nerve root is already involved. But in S4 area, as you go lower, the occupancy of the root becomes smaller. So even with a neural foramen fracture, patient might not have a nerve root injury. So always look for which foramens are involved, and that should give you a good suspicion as to whether patient might have this deficit or not. Okay. Then coming to classification systems. So in sacrum, if you observe literature, there are multiple classification systems mentioned. There are about 8 or 10 classification systems given in every textbook. We are not going to study all of them, because what we need in our clinic classification system is to be able to describe all types of sacral fractures. It has to give us an information about neurological deficit, and also it should help us with our clinical examination. So we are only going to study 4 important classification systems, which actually are different because they give us different information. Now the basic classification, this again is not even a classification system. The basic way of remembering or understanding sacral fractures is they can fracture in 2 planes. One, you can have a longitudinal fracture, and this usually happens when there is an associated pelvic injury. So when you have a pelvic fractures session, in that you will listen about different classification systems, anterior posterior injuries, lateral compression injuries, vertical shear injuries, and in such injuries, whenever there is injury to the pelvic ring, there can be an associated injury posteriorly to the sacrum as well, and these usually lead to longitudinal fractures, and majority of sacral fractures are associated with pelvic ring fractures, and they are longitudinal fractures. But you can also have another type of injury where there is an injury occurring in a transverse plane. Those are called as transverse fractures. Okay, so 2 types of fractures you have to understand: transverse fractures and longitudinal fractures. Now longitudinal fractures, the treatment for that will always be included in the pelvic lecture. So whenever you are seeing pelvic lectures, they will tell you about how to manage a sacral fracture that has occurred in a pelvic ring injury. We are going to primarily talk about transverse fractures. Of course, we will talk a little bit about longitudinal fractures in the classification system, but when it comes to managing, it's mostly these transverse fractures that we have to address. Okay. Now longitudinal fractures, like I told you, the injury usually transmits to the pelvic ring and then goes into the sacrum. Okay, so most sacral fractures are from these longitudinal injuries, and they are always associated with pelvic ring injury. About 90% of the time longitudinal fractures are associated with pelvic ring injury, and they're commonly seen in lateral compression type of fracture and vertical shear type of fracture. In lateral compression and vertical shear, they are unstable fractures because joint is disarticulated, and they have hemodynamic instability. Because pelvic ring injury is there is going to be hemodynamic instability. Okay. Then coming to transverse fractures. So the pattern in transverse fractures is it's usually seen in people who fall on buttocks or extended legs, that is fall from height. And the most common pattern of fall from height is patients attempting suicide. So these are called as suicidal jumpers fracture, transverse fractures. They are less common compared to longitudinal fractures. Therefore 5 to 16% of roughly all sacral fractures, most of them are longitudinal fractures. And usually when you see this pattern of fracture, they're not associated with any other fracture. You might not have a pelvic ring injury, but of course you might sometimes have calcaneum or lumbar fractures or thoracolumbar fractures, but usually not associated with pelvic ring injuries. Then let's talk about classification systems. So many people have tried to describe sacral fractures, but nothing has been more effective and more commonly followed than the Dennis classification, a very simple classification system that talks about zones of where the fractures occurs. And this is important for us because it tells us about whether this patient is likely to develop neurological deficits or not, and that is a very important information that we need to know. So in Dennis classification, he's divided them into 3 zones. You can have fracture occurring at the sacral ala region, that is called as the alar zone. That can be fractures occurring here, or you can have fractures occurring in the foraminal zone where foramens are present. So that is zone 2 or foraminal zone fractures. And lastly is fractures that occur in the center part where you have the sacral body, and that is called as a central zone fracture. Okay, so that is zone 1, zone 2, zone 3, and this actually is giving us very good information because if the fracture occurs in the sacral ala, there is less chance of any nerve injury. Maximum you might have an L5 nerve root injury. If the fracture is occurring in the foramen, again in S1, S2 nerve root, there can be a foraminal injury leading to a nerve root injury. So there is a slightly higher chance of neurological deficits, but not as much as in central zone. In the central zone, you have your quad equina nerve roots present. So if there is fracture of the central zone, very high chance of patients having neurological deficits, and that is basically what Dennis classification is. Let me quickly tell all of that again. So in LR zone, the fracture has to remain lateral to the neuroforamen throughout its course. So let me quickly tell you all of those Dennis classifications again. So in Dennis zone 1, that is the alar zone, the fracture remains lateral to the neuron foramen throughout its course. That means if the fracture starts somewhere here, it should also exit somewhere here. If that fracture travels like this, that is not a zone 1. It has to be a purely LR zone fracture, and the chance of neurological deficits here is very less. It is less than 5%. Like I told you, the only fracture you might get is if there is an upper sacral ala fracture, your nerve root of L5 might get involved and patient might come to you with a foot drop. Okay, that is an LR zone fracture. In zone 2 fractures, you might have a foraminal injury, that is fractures are located in the transition area between the sacral ala and the body, and it can involve one or more neural foramen while remaining lateral to the spinal canal. It will not go into the central zone. And here, mainly at the S1, S2 neural foramen, if there's an injury, you have a chance of neurological injury. So 28.4% incidence of neurological injury, higher than alar but less than central. Okay, mainly S1 and S2 nerve roots are getting involved. And in this foraminal zone, again I'd like to introduce a second classification system. The reason I'm interrupting between Dennis zone is because this is in mainly Dennis zone 2s that you see. So what happens in Dennis zone 2? In Dennis zone 2, we have fractures traversing through the foramen. Now, whenever there is a fracture like that going through the foramen, it is very important for us to see one structure, and that is your L5-S1 articulation. Because that really defines whether the patient has lumbosacral stability or not. And that is why there was a new classification system made called as the Eilers classification, which does not talk about anything else but lumbosacral stability. Where is the fracture affecting the L5-S1 facet joint? So look at this. This is type 1. In type 1 Eilers, what happens is the fracture goes through the foramen, like you can see here, but it goes lateral to the L5 facet. It can fracture the transverse process, but it goes lateral to the L5-S1 facet joint, and that is why this has a intact lumbosacral articulation. So this is lumbosacral stability is present in type 1. Now look at type 2. In type 2, again you have a foraminal fracture going in like this, and this fracture now goes through the L5-S1 facet joint, and this leads to lumbosacral instability. This is Eilers type 2, where it is going through the L5-S1 facet joint. Now the third fracture type in the foramen can travel through and then go medial to the L5-S1 facet joint. This again causes lumbosacral instability. Okay, so type 1 Eilers is stable, type 2 and type 3 are unstable, and in these two cases, In cases of lumbosacral instability in type 1 and in type 2 and type 3, you have to do a lumbopelvic fixation. So your treatment cannot be anything else other than lumbopelvic fixation, because there is lumbosacral instability. You have to do a fixation of that, and that is how your Eilers classification becomes important. Now let's resume back to Dennis. So we've discussed Dennis 1, Dennis 2, that was alar and foraminal. Dennis 3 is a more severe type of fracture, because here the fracture is occurring in the center where there is a spinal canal, where there is quad equina nerve roots present, and the chance of neurological injury here is 56.7%. The highest chance of neurological injury is seen in Dennis zone 3, and out of all of these patients having neurological deficits, 76% of them will have bowel, bladder and sexual dysfunction. Okay, and that is why very important to pick up whether a patient has a Dennis zone 3 fracture or not. Okay, and this can be of severe types as well. You might have an H-shaped 3A, Dennis column 3A, or you might have a U shape like I showed you in the anatomy as well, or you can have a lambda type of fracture, or you can have a fracture going through one end and another. This again is a lambda, or you can have another fracture going in like this. So these are 3A, 3B, 3C. This is not very important to us, but we have to understand injury patterns can be of different types. H, U or lambda type of Dennis column fractures can be there. Another is severe type of sacral burst fractures. That again comes in zone 3, but here the fracture is involving both your horizontal and your longitudinal plane, and in this cases there is a high chance of sacral body retropulsing and going into the canal, and that can lead to severe neurological deficit. So you can have different patterns of zone 3 fractures, but please understand zone 3 is the worst one, where there is the highest chance of neurological deficits occurring. Now that was about your Eilers classification and also about your Dennis classification. Another pattern of fracture that you will commonly see because of this transition zone that I told you about. So whenever you have a transition zone like this in between a thick S1, S2 and a very weak S3, S4, what happens is in patients having a trauma where there is direct impact of this bone, there can be a fracture occurring in the sagittal plane, a fracture like this, because of which there might be angulation. There might be a sagittal plane angulation or a sagittal plane displacement. As you can see in this image here, there is a sagittal plane displacement. And till now, if you observed all the fractures that we've talked about, none of the fractures describe these kind of fractures. None of the classification describe about these types of fractures. So that is why we have an important classification system called as a Roy-Kimmel classification, which talks about sagittal plane angulation and displacement. They basically divided them into 4 types. Type 1 is where you have a hyperflexion injury, and because of this hyperflexion injury, there is kyphosis in this plane. You can see there is kyphosis, but there is no displacement. Can you see? There is no displacement. Your lower and upper sacral fragments are sitting over one another. There is no displacement. So less chance of instability and less chances of neurological deficits. Okay, so that was type 1. In type 1 Roy-Kimmel, you have hyperflexion, kyphosis, no displacement, less chances of instability, less chances of neurological deficits. Then you have type 2. This again is a hyperflexion injury. But here you can notice how there is a partial posterior displacement, not complete. There is still some articular contact that is maintained. So there is a partial posterior displacement, and this is more unstable, and there is some chance of neurological deficits, higher chance of neurological deficits. Then let's look at type 3 Roy-Kimmel. In type 3 Roy-Kimmel, the mechanism is different. Here your sacrum and your pelvis is going into extension. There is extension injury here. And because of this extension injury, there is a complete forward displacement of the sacral segment. There is complete forward or anterior displacement, and obviously this has the highest instability rates and highest chances of neurological deficits. Okay, that was type 3. So this was originally the classification system given by Roy-Kimmel, where he introduced type 1, type 2 and type 3. But then another type was given by Strange, Watson and Libek. Strange, Watson and Libek, they came up with the type 4. Here what happens is there is no displacement, there is no kyphosis, but there is axial loading, which causes a fracture of S1 and S2. There is fracture of S1, S2 and axial loading, but no displacement, no kyphosis, and these patients also develop some instability and neural deficits. Okay, this is type 4 given by Strange, Watson